Yeah, so by definition of lobectomy is a surgical removal of one of the lobes of the lung. There's 3 lobes in the right lung, 2 lobes in the left, an upper and a lower. The right has an upper, a middle, and a lower. And what's been kind of borne out in the literature since lung surgery's been carried out, namely for cancer, is the best or the gold standard we have for removal of a lung cancer is a lobectomy. And the thought is you get a good margin around the tumor, but not only that, but you take all the lymph nodes with the lobe that drain the tumor. So that gives the patients the best chance for both long and short-term cancer-free survival. Our default for a lobectomy or any lung operation, if it can be done from an anatomic and patient safety perspective, is a minimally invasive approach, namely a robotic approach, where the patient receives 4 to 6 small incisions, and we can remove the lobe that way. And that gives obvious benefits with minimally invasive surgery, less pain, shorter hospital stay, and faster and better patient recovery. Now, there are some lung tumors that are not amenable to a minimally invasive approach, in which case we perform the larger incisions or the thoracotomy to safely remove a lobectomy or a tumor. When the patient comes in for surgery, they're greeted by both myself, the surgeon, and the anesthesia team. And they'll go into the operating room. We use what's called single lung ventilation, so they get a special breathing tube placed by anesthesia that allows us to see and work within the confines of the chest cavity, whether it be the right or the left. And then when we do a lobectomy, what defines the lobe anatomically is each segment of the lung or the lobe has an artery, a vein, and an airway or a windpipe going to it. So with the robot, we are able to encircle those structures and divide them to detach that lobe and then subsequently remove it. So before we do any surgery, especially for cancer, there's a thorough preoperative workup. We do staging scans, namely a PET scan, and we also check the patient's heart function. A lot of these patients will get a stress test or an echocardiogram because a lung surgery, even though it's not a heart surgery, it still stresses the heart to some degree. So we make sure your heart's healthy enough to withstand the operation. And we also test the lung function. We perform pulmonary function testing, and as long as the patient performs above a certain threshold, meaning it's safe to remove that lung, then we offer them the surgery. So if a patient who's a candidate in that regard, they expect that workup, and if that workup is satisfactory, then they're candidates for surgery, which is the gold standard for removal of early stage lung cancer. For a typical robotic lobectomy, we use 5 small incisions. By small, I mean about the width of the thumb, and they're horizontal, and depending on which side the tumor is, right or left, they're along the side, from the back all the way up to the sternum, about 1 handbreadth apart. The primary surgeon, once all the ports are placed, that allows us to get our instruments in, attach those to the robot, and get to work, sits at the robotic console. And the advantages of the robot is, of course, it's minimally invasive surgery, but you get a high-definition 3-dimensional camera view, which helps the surgeon a lot in regards to anatomy and getting around these structures safely, namely the artery, the vein, and the windpipe. There's a bedside assistant who assists with retraction from the actual bedside and passing of instruments and changing of instruments that we need to do the operation safely. From the time we place the ports, a typical robotic lobectomy takes around 2 hours. We have what's called a post-operative pathway where we try to get the patient a maximum a chance at a good, swift recovery. So to answer your question, every patient, they'll wake up with a chest tube. That chest tube is pulled out at the earliest time, with the goal being a post-op day 1 or post-operative day 2 chest tube. The patient will get daily lab work and a chest x-ray to make sure that the lung's re-expanded and looks as it should. And once the patient is up moving around, doing well with their diet and feeling better, we will discharge that patient home. Usually that falls around post-operative day 2 to 4. When they're in their hospital, they usually go to a step-down unit, and it's a multitude team approach. So not just the surgeon, but the nurses, physical therapy works with you to maximize recovery and expedite the recovery. And it's usually a 2 to 4 day stay hospital in the step-down unit, with the goal of ultimately getting the patient home within the first 3 to 4 days. So even it's minimally invasive, so the pain is much reduced compared to traditional open surgery with namely a thoracotomy. We do treat the patient's pain post-operatively, and we also, before we close the patient at the end, we perform what's called intercostal nerve block with a long-acting local anesthetic that helps greatly reduce the post-operative pain control. Having said that, it is reasonable to expect some soreness and some pain post-operatively that gradually gets better and even goes away within the first 2 weeks after the operation. I see the patient in the office within 1 week of discharge. And there's been actually literature to show that that improves outcomes long term of lobectomy patients being seen within a week. So I do that, and as long as they're doing okay, I'll see the patient 2 to 4 weeks after that initial postoperative visit. And if we do the lobectomy for a lung cancer surgery, a lot of the times the final pathology will determine whether or not what the final stage is after taking the lobectomy, all the lymph nodes. And some of those patients, if they fall in postoperative stage 2 or stage 3, will be referred for potential chemotherapy. If they're stage 1, we follow them with CT scans every 6 months for up to 5 years to ensure that the cancer doesn't return. So I follow that patient a minimum 5 years after the surgery, periodically. Yes, well, our cancer patients all get what's called a multidisciplinary approach. So even if they don't need chemotherapy after, I still refer that patient to oncology for evaluation, another set of eyes, if you will, to make sure that all the T's are crossed and I's are dotted. So it is a multidisciplinary approach. Not just with the thoracic surgeon, but with the oncologist. Radiation oncologists sometimes will be involved to help manage care of these patients, and pathology as well. Yeah, so for a lung cancer patient, the gold standard borne out in the literature over a long period of time has been lobectomy. So with the preoperative testing that we get, the echocardiogram, the stress test to look at the heart, or the pulmonary function testing, a lot of the preoperative discussion I have with that patient regarding risk is based on those studies. Some patients who have borderline preoperative testing and we offer them surgery, they may be at a little higher risk for complications. So we have a discussion about that. But I ballpark of all the lobectomies I do, obviously you want that risk to be minimum. I ballpark a risk of a major event like a mortality or a major complication around 1% to 2%. So obviously the benefit of getting rid of a cancer will outweigh that. This is what we do. We're a specialty program, so we have a lot of experience, and we have a very, like I say, a fine-tuned approach to not only do the operation, but evaluate you preoperatively, make sure you're set up for success and to safely get through the operation and recover. And postoperatively, we're with you the whole way, like I said, up until 5 years after the operation, to make sure the cancer's gone, it doesn't come back, and that you progress well and do well.